क्या क्या? नहीं हाँ, तो वहाँ नहीं दिखेगा।
नहीं, उसमें पीपीटी पे नहीं आ रहा है सर।
नहीं आ रहा, ये लैपटॉप में है।
आप अपना लैपटॉप देंगे तो देखो। कौन सी एचडीएमआई पोर्ट है?
HDMI नहीं है आपका।
सी टाइप है ना?
सी टाइप, हाँ सी
ठीक है।
टाइप।
एक बार चेक करो।
थोड़ा थोड़ा सा आता है, अपने जाने के लिए मैं नेक्स्ट टाइम
So should we start? Good morning, one and all. For today's clinical grand rounds, on behalf of Department of Anesthesia and Critical Care, we are presenting anesthesia management of pediatric liver transplant. First part, I'll be covering about preoperative evaluation. Now, the current to assess general medical and surgical histories and examination, to optimize potential anesthesia-specific risk factors which are we encounter during surgery, and to explain the role of anesthesia team in context to liver transplant. It's a multidisciplinary team approach comprising transplant surgeon, pediatric hepatologist, anesthesiologist, critical care specialist, ID specialist, and transplant coordinator, with support from various specialties like cardiology, nephrology, neurology, pulmonology, radiology, dietitian, and occupational therapist. Indication for pediatric liver transplant is broadly divided into three major categories: emergent indication for ALF and ACLF, urgent indication for metabolic disease which are refractory to surgical and medical therapy, and oncologic disease like unresectable hepatoblastoma. Elective indication, etiology-wise, most common etiology is biliary atresia, followed by metabolic or genetic diseases. In biliary atresia, post unsuccessful PSI, if total bilirubin is more than 6, there should be prompt LT referral. If it is between 2 to 6, we should consider LT. Other indications are like nutritional and growth failure, complications of portal hypertension like variceal hemorrhage and intractable ascites, infection, recurrent cholangitis and STP, and neurologic indications like advanced encephalopathy and intractable pruritus. So children are not small adults. We should, they are quite different in all the systems. Like I'll be discussing mostly on respiratory and cardiac differences. Their oxygen consumption is quite high, that is 6 to 9 ml per kg per minute as compared to adults, which is only 3 ml per kg per minute, which causes rapid desaturation as there is very low buffer time during FP. Their lung mechanics is also different. They have high chest wall compliance with low lung compliance, and their ventilation is diaphragmatic dependent. So this accentuates once patient comes with abdominal distension, they are prone for atelectasis. Their FRC is very low as compared to adults, which further decreases under general anesthesia. This means that airway closure occurs during tidal breathing only, because the closing capacity of airway is more than the functional residual capacity. In cardiac system, their cardiac output is heart rate dependent because they have fixed stroke volume due to non-compliant LV, and bradycardia means cardiovascular collapse. Their autonomic tone is primarily parasympathetic dominant, which causes profound vagal response leading to bradycardia during direct laryngoscopy and suction. Airway-wise also, infants are different. They are generally considered as difficult airway due to large occiput, thin underdeveloped mandibles. They have large tongue, highly placed larynx, omega-shaped epiglottis, and narrow subglottis. If a child comes with airway reactivity and mucosal edema leads to even 1 millimeter decrease in circumferential diameter, their airway resistance increases exponentially. So coming to airway assessments, history, we take birth history, any preterm history or any relevant birth history, ICU admission, any previous surgery, any prior anesthetic exposure. Current or recent symptoms of URI, difficulty in breathing, hoarseness, or noisy breathing. Red flag signs for obstructive sleep apnea, snoring, and apneic spell during sleep. And syndromic child already potential difficult air. So apart from regular Mallampati classification, which we use for adults, we have to see tonsillar enlargement also in pediatric population. For pulmonary system evaluation, routinely we do history and physical examination, chest X-ray, ABG, saline contrast echo, but in specific cases, we need HRCT lung, technician labeled abdomen scan, and cardiac catheterization in case of creatinine. So here I'll be discussing case in brief. A 9-month-old male child with advanced CAD had recurrent hospital admission with URTI, LRTI, had reactive airway. Our aim was to find optimal window for transplant, but malnutrition, immunocompromised state, recurrent infection, and disease severity were making our decision difficult. Despite best efforts, intraoperatively, patient had bronchospasm, and in first week post-op, he developed pneumonia. So respiratory tract infection is one of the major problems which we encounter in cirrhotic children. Children with recent URTI have 2 to 3-fold incidence risk of perioperative adverse respiratory events, which is laryngospasm and bronchospasm. Risk factor being age less than 2 years, history of prematurity, higher grade ASA status, and pre-existing respiratory programs. History of pre-op respiratory complication is significantly associated with post-op respiratory issues, and some studies have shown that children with even latent infection face higher mortality rate compared to non-infected children. This is a flow diagram. Once child present to us with URTI, we have to assess whether the child has mild to moderate URTI. If the surgery is emergent, we have to see individualized risk-benefit ratio. Will pre-medicate the patient with bronchodilators, and we have to formulate anesthesia plan like FEVA and other things. But if the patient comes with severe URTI, it's always favorable to postpone and re-evaluate the patient after 2 weeks or once the full symptoms resolve, because they are immunocompromised and there is very high risk of perioperative respiratory arrest. So hepatopulmonary syndrome prevalence is quite high in cirrhotic children, most commonly in biliary atresia. Diagnosed by room-air PO2, contrast-enhanced echo to detect stunting, and technetium level albumin scan. Severity is if patient have very low PO2, shunt fraction is more than 20, and this problem worsens over time. There is a correlation between preoperative PO2, that is partial pressure of oxygen in blood, and recovery. Although there is no significant difference in overall post-LT survival, but in type 1 HPS patient, there is greater survival noted in children with whom, if 100% FiO2 is given and PO2 is significantly improved. Patients with very low PO2 experience longer mechanical ventilation time and extended ICU. There is, with availability of ECMO, however, any grade of HPS is not a contraindication nowadays, and grading is important for preparedness. Portopulmonary hypertension incidence is very less in children, and we do screening echo. If right ventricular systolic pressure is more than 40, we have to further investigate in terms of right heart catheterization to measure mean pulmonary artery pressure. If it is more than 45, patient goes for medical therapy. If they are responders, they qualify for MELD exception for bigger children. But children under 12 years of age, MELD exception algorithms are not yet fully developed. And in non-responders, it's likely contraindication for transplant. These are the various liver disease associated with respiratory involvement, like cystic fibrosis have obstructive lung disease and the risk of infections. Alpha-1 antitrypsin manifest in adulthood as COPD. So LT is basically protecting the chest. Niemann-Pick disease causes restrictive lung disease. Now coming to cardiac evaluation. So all patients undergo ECG and echo. In echo, we screen for valvular or septal defects and cardiomyopathy or POPH defects. So if patients have all these problems, then we should go for cardiac catheterization or device closure or surgical repair. And severe PH may even preclude LT. Cardiac catheterization, as I said, is indicated in septal defects or valvular anomalies. Dobutamine stress test is rarely indicated if the patient comes with cardiomyopathy to know whether the heart can withstand the stress or if patient requires combined heart liver transplant. Coming to cirrhotic cardiomyopathy, earlier it was thought that pediatric patients do not have much of cirrhotic cardiomyopathy, but recent studies, including one of the studies from our institute, has shown that it is quite prevalent in pediatric population as well. In fact, the prevalence doesn't depend upon the etiology, but the severity of the liver disease. CCM was measured with left ventricular mass index, which was found higher in unsuccessful Kasai and unoperated biliary atresia. And higher serum bile acid was also seen in patients with CCM. There was an decreased overall survival at 12 months. And however, post-LT, there was no significant effect on mortality seen in this study. And most of the patients recovered after 6 months. The implication of CCM is great in LT. As an early stage patient has increased cardiac output due to reduced SVR, and they require careful fluid management. But in later stage, due to reduced cardiac output, there is increased inotropic requirement and mortality risk. They have rhythm abnormalities like chronotropic incompetence, which contributes to impaired ability to maintain cardiac output under stress. Here I'll be discussing briefly a congenital heart disease patient who was 19 months old, who had biliary atresia related CLD with moderate HPS and a large Austin secundum type of ASD. Multidisciplinary team advised closure of ASD prior to LT, so patient underwent device closure. and there was no perioperative adverse cardiac event. Congenital heart disease pathophysiology should be well understood. There is amplified hemodynamic stress during LT, particularly during reperfusion, because there is a drop in SVR, large volume requirement, electrolyte changes, and metabolic acidosis, which leads to potential cardiac events like profound hemodynamic instability, arrhythmia, decompensation of heart failure, thromboembolic events, and even cardiac arrest. So timing and strategy in combined heart liver disease is very important. There is always a surgical dilemma whether heart or liver first. So heart first means risk of worsening liver failure. Liver first leads to increased cardiac complication. Clinical decision is based on complexity of cardiac anomaly. Patient with stable cardiac function should undergo LT first, and patient with complex cardiac anomaly require cardiovascular procedure before LT. These are the various liver diseases associated with cardiac anomaly, like Alagille syndrome has tetralogy of Fallot, branch pulmonary artery stenosis, which is the leading cause of death in infancy. Biliary atresia, as we have seen, associated with shunt problems and cirrhotic cardiomyopathy. And other problems are associated with cardiomyopathy. Coming to neurological assessment, routinely we do history and clinical examination, but in special scenario, we go for brain imaging as well. Wilson disease, LT, is considered as a brain indication on case-by-case basis for severe neurological Wilson disease. Sometimes these children present with dysarthria and bulbar involvement, so we should take special aspiration precaution. Beyond fasting, we should use PPI, prokinetics, and strict anti-aspiration protocols. Patient with tyrosinemia sometimes may present with acute neurological crisis with autonomic dysfunction and motor neuropathy. But in this scenario also, LT is curative, so the patient should go ahead with it. Renal assessment, routinely, we do renal function test, but in special scenario to rule out polycystic kidney disease, we need imaging as well. The most common cause of renal dysfunction is hypovolemia. Serum creatinine has limitation, so cystatin C performs better. The incidence of HRS is very less in pediatric population, but true incidence may be little higher because there is no specific pediatric diagnostic criteria. Management is similar to adults, and SLKT for HRS in pediatric population is rare. These are the genetic diseases and associated renal dysfunction. Pre-LT dysfunction is seen in tyrosinemia, primary hyperoxaluria, which requires SLKT, and congenital hepatic fibrosis. Post-LT exacerbation is seen in alpha-1 antitrypsin deficiency and Alagille syndrome. Last but not the least, nutrition is very important for liver transplant patients. Weight alone often overestimate the health due to fluid retention or organomegaly. So, serial tricep skin fold and mid-arm circumference, apart from other anthropometric measures like weight, height, weight for age, are the most accurate assessment. There should be aggressive nutritional support prior to LT to optimize patient and graft survival as well as brain and long-term cognitive outcome of the child. To summarize, we should account for pediatric adult physiological difference along with liver disease-related changes, adopt an individualized patient-specific approach, ensure close coordination with hepatology and surgical teams, and be vigilant about associated anomalies and multi-organ involvement.
Any questions or comment, or we can take it at the end from anyone? Maybe at the end we can take the rest.
Thank you, Dr. Shweta. I'll be continuing with the talk about pediatric liver transplant. She discussed about the preoperative assessment. I'll be discussing about the intraoperative management and the postoperative management. As told by Dr. Shweta, the anesthetic plan begins before the OR. Each examination of each system is important, and each system demands independent assessment with a thorough preoperative examination. The various concerns we face are preoperative pathophysiology, as discussed by Dr. Shweta. There are many associated syndromes, metabolic, cardiac, renal dysfunction, portopulmonary syndrome, which should be assessed preoperatively. The second comes technical challenges of difficult airway in the pediatric patients that was discussed by her, difficult IV access, particularly The children are very small. We require large bore IV access to account for the massive transfusions. Then comes the physiological disturbances which happen intra due to hemodynamic instability during cross clamping, blood loss, the various electrolyte disturbances that happen, and issues associated with massive transfusions like hypothermia, coagulopathy. So the induction of anesthesia should be tailored to the severity of the liver disease based on the preoperative cardiac status, hemodynamic status, and electrolytes. The normal induction method is IV induction. We normally keep an IV cannula before the surgery starts and induce the patients with propofol. In selective patients with hemodynamic instability, we can use ketamine. Maintenance is generally done with sevoflurane anesthesia, which helps for early extubation. Muscle relaxation or cystatracurium is preferred, and for analgesia, continuous opioid infusion of fentanyl. It is paramount to avoid hypothermia by using active and passive methods. Now, coming to the vascular axis, the vascular axis is often the Achilles heel. In the transplant, the children are very small. They have previous admissions, and it is difficult to take IV access. Central venous access is determined according to the patient's weight and age. Here in ILBS, we prefer two central venous accesses. One is a central line. We put a 4.5 to 5.5 French central line in the right IJV for inotropes and electrolyte infusions. And we put an advanced venous access, that is a 5 French sheet that is meant for massive transfusions. That also is put in the right IJV. So the right IJV in children, the size will be around 1 to 2 mm, sometimes 3 mm, and it is difficult to put both these lines in the single IJV. So it requires special expertise. Same with the arterial lines. Some institutes put 2 arterial lines. We prefer a single arterial line in the femoral side. Again, the gauge is the lumen is very low, so there's a high chance of failure. So a good vascular access is paramount to start the transplant. Coming to intraoperative monitoring, we use standard ASA monitors. Along with that, we use arterial BP and central venous monitoring. Along with that, selective monitors are used in various conditions. TE can be used in older children when patients have congenital cardiac disease. Pulmonary artery catheter is not used in all conditions. It is used in POPH. Again, a good pre-op evaluation will help to determine which monitoring is used when. Dynamic and volumetric indices like pulse pressure variation is used to monitor the beat-by-beat variability and assess the requirement of fluid. Coming to the 3 surgical phases, each phase carries distinct physiological challenges. The anesthetist must anticipate and prepare for these transitions and not just react to them. The first phase is the pre-anesthetic phase, where the hepatectomy is done, normally lasting 2 to 4 hours. The major risks are blood loss from varices, adhesions, and collaterals. The patients can have major hemodynamic instability from ascitic drainage during this phase. Next comes the anhepatic phase, which starts with the portal vein clamping and as IVC clamping. Here, due to clamping of the IVC and portal veins, there's decreased venous return, can cause hemodynamic collapse. So vasopressors have to be used. Noradrenaline is the first line. Next comes the neohepatic phase or the post-reperfusion phase, where we face problems like PRS. Coming to the first phase, pre-anesthetic phase, in the initial stages, there's ascitic drainage. We have to watch out. The sudden release of large volume of ascites can lead to acute drop in the preload. The ascitic fluid that has been lost should be replaced by albumin around 6 to 8 ml per kg, and vasopressors should be given accordingly, according to the hemodynamic status. The norepinephrine and vasopressors are preferred for vasoactive management, and they are preferred over volume loading. Here, aggressive fluid loading increases the portal pressure, can further worsen the venous hole. So hemodynamic management should be based on vasopressor. The hemoglobin PRBC should be transfused based on hemoglobin targets. A target of 7 to 8 is normally set. FFP and cryoprecipitate should be based on TEC and ROTEM, and normothermia should be maintained. At core temperature more than 36 should be targeted, and glucose and electrolyte should be monitored. The child with end-stage liver disease enters the operating room with impaired glucose neogenesis, poor electrolyte reserve, and there's no thermoregulatory barrier.
So all these three require active management. The goal of temperature management should be to maintain a temperature more than 36 degrees. Passive warming should be done by insulating all surfaces, warm the theater to 24 degrees. Active warming is given by flare hugger in the upper and lower extremities. All IV fluid should be warmed. The glucose management should be, the glucose goals are to keep the glucose between 80 to 180 milligram per deciliter, avoid hypoglycemia. ABG should be done hourly to monitor the glucose, and a 1% dextrose infusion is preferred in the pediatric population. Electrolyte disturbances are quite common. Potassium should be maintained between 3.4 to 4.5, and ionized calcium level should be more than 1.1. Both of these can be maintained by infusions, and when potassium is high, we can use GI drip. Avoid rapid correction of sodium. And all this should be monitored as. Coming to the anhepatic phase, this is the most metabolically hostile phase. There is no functioning liver, and all electrolytes and acid-base derangements must be treated proactively. In this phase, the IVC clamping occurs. In the conventional clamping, there's both suprahepatic and infrahepatic clamp. And then here we use piggyback technique where there's a side clamp. Both have physiological impacts. There's decreased venous return, can cause sudden hypotension. Here, the main management is using vasopressors. If we rush IV fluids, it can cause graft congestion during reperfusion phase. Next comes the reperfusion phase. Here, we face the challenge of post-reperfusion syndrome. PRS occurs in about 30 to 40% of the patients. It is defined as more than 30% fall in MAP for more than 1 minute within 5 minutes of reperfusion. So, how to prevent this main thing is optimization of the patient pre-hand and prevention. Pre-hand clamping, there should be a checklist. Temperature of the patient should be more than 36 degrees. pH should be more than 7.3, potassium more than 4.5, calcium more than 1.1. We should keep epinephrine, adrenaline, calcium chloride, and phenylephrine ready. Defibrillator should be connected and on. The complications we face post-reperfusion are hypotension, which happens in 30%, arrhythmias, patient can have VT, VF, cardiac arrest, and hypothermia. So it is paramount to ensure prevention of this by following the checklist. Coming to the last phase, the neohepatic phase or the graft reperfusion. Here there is, once the graft is perfused, the attention shifts to hemostasis, vascular anastomosis, integrity, and planning for closure. Here there is still persistent coagulopathy and bleeding from the vascular anastomosis. Focus should be on the fluid management and coagulopathy management. Once the graft is put, indicators of good graft function include acid-base corrections, electrolyte abnormalities improve, and urine output may improve. The critical risk at this period in pediatric population is hepatic artery thrombosis. In adults, around 2% risk is there, but in children, there's higher risk. To prevent this, we should keep a target hemoglobin of 8, PCT of around 25, and IV heparin infusion can be given. Now, in the end, once the patient is ready for closure, tight abdominal closure should be avoided if the peak pressures are increasing. Stage closures and Bagota bag can be considered. The intraoperative approach to coagulopathy should be based on TEG and should never be based on values of INR. In the pre-anhepatic phase, unnecessary transfusion should be avoided. It triggers volume overload. All the transfusion should be based on viscoelastic triggers. R time more than 10, we can transfuse FFP of 10 to 15 ml per kg. A prolonged K time, cryoprecipitate can be given. Whenever the angle is low, then also we can transfuse cryoprecipitate. And whenever products are needed, surgical field should be looked at. Unnecessary transfusion causes volume overload. In the neohepatic phase or the post-reperfusion phase, there are chances of fibrinolysis. A TEG should be done, and if present, should be treated. But most important in the neohepatic part is prevention of HAT. Any signs of hypercoagulability on TEG should be corrected with heparin. Fluid management is mostly with balanced crystalloids. The goal is euvolemia, avoiding both hypovolemia and fluid overload. Here we use plasma lights and 5% albumin for replacement of the ascitic fluid loss and volume maintenance. Use of 5% albumin gives better oncotic retention decreases edema as compared to crystal burn. Once the surgery finishes, a planning for extubation should be done. Early extubation is achievable. It should be tried when there are stable hemodynamics, the duration of surgery is short, there's minimal blood loss. Studies have shown that around 50 to 60% of the patients are eligible for extubation in the operating room itself. All standard criteria should be, extubation criteria must be strictly followed to ensure safety. Decision depends upon the patient factors, how the surgery went, how the graft is, and the institutional expertise. Careful selection of on-table extubation lowers reintubation rates and shortens ICU stay. Contraindications for extubations are for large volume of transfusions given hemodynamic instability and anticipated reoperation. In the ILBS data from 2024 to 2026, 34 pediatric liver transplantations were done. Immediate extubation on the table, we could do of 11 patients out of 34. All these patients had good outcomes. There was 0% mortality. 10 patients we could extubate the next day, and 13 patients had required prolonged ventilation before extubation. These patients had higher mortality. So from here we see early extubation was achievable in 32% of the LT recipients. I will be discussing this data more. Now, once the transplant is over, next part comes the most challenging part, post-operative management. Here we have to navigate cardiopulmonary coagulation and fluids management challenges. The ICU is the transition phase. Normal here, management of the child is difficult because they are often zero reserve patients. I label them as zero reserve because they have sarcopenia, chronic malnutrition, multi-organ dysfunction are already present in these children, which are compounded by the surgical insult of transplantation. Then there's the challenge of the LDLT, where the left lateral segment grafts in small infants can cause large size scenarios, can lead to abdominal compartment syndrome and vascular kinks. So a seamless handover between the operating room and the ICU should be done. This is a dynamic phase. There should be no gap in the vasoactive management, ventilatory management, and anticoagulation. The primary ICU goals are to maintain a group graft perfusion, to have MAP targets and to achieve them, to avoid hepatic artery compromise, to ensure adequate oxygen delivery, to prevent thrombosis, and to ensure metabolic recovery. Coming to the first part of ICU management, hemodynamic management, the post-transplant child is vulnerable to vasodilatory shock. There are multiple concurrent mechanisms which must be addressed simultaneously. The postoperative causes of postoperative vasoplegia are residual effect of the general anesthetic, which causes peripheral vasodilatation. Capillary leak decreases the circulatory volume. Surge from ischemia, reperfusion injury, residual and hepatic phase acidosis, and delayed clearance of vasodilatory metabolism. All these causes decrease in MAP in the first 1 or 2 days postoperatively. Here we use the vasoactive strategy should be used to, and we should not rely only on fluids. Norepinephrine is the first line vasoactive agent used for distributed shock. After that, vasopressin is used. The monitoring targets should be set. A MAP of more than 65 can be targeted, and in younger children, infants, a MAP of 55 should be targeted, and heart rate should be targeted within normal range. A daily Doppler ultrasound should be done to monitor the hepatic artery and portal flow. Next comes the respiratory management. This is the most difficult part in the ICU for pediatric population. As told by Dr. Shweta, these patients are not young adults. They have unique challenges because they have lesser respiratory reserve than adults. So whenever the child comes to the ICU who has not been extubated, a lung protective ventilation strategy should be used. FiO2 as low as possible. We should try to keep a low FiO2, titrate PEEP to as low as the possible level. And we should assess for extubation readiness from the first postoperative day. How to assess for whether the patient is ready for extubation? There should be no mechanical barriers to the lungs. There should be no abdominal distension. The large graft should not prevent lung expansion. The child should be awake. He should have adequate muscle reserve, generate adequate spontaneous tidal volume, and have an intact gag reflex. The ABG should reflect normal values. when the pressure support is of 8 to 10 and a PEEP of less than 5 on pressure support ventilation. Hemodynamics should be stable, no escalating vasoactive requirements, MAP stable without the need of boluses, and there should be adequate graft function. That means there should be the lactate should be decreasing, bile should be the graft should produce bile, coagulopathy is improving, and no active bleeding. If the patients satisfy all these criteria, we should go ahead with extubation. If not, ventilation should be continued with a lung protective strategy, and daily weaning trial should be given. Now, once the child is extubated, non-invasive respiratory support is given. It is a bridge between extubation and full respiratory independence, and it should be used proactively, not as a rescue measure. Here, we use high-frequency nasal cannula as a bridge, the immediate post-extubation. Its advantages are that it gives heated, humidified oxygen, generates low level of PEEP, decreases the work of breathing. Here, we use it as first-line post-extubation. We use it in patients with HPS with refractory hypoxemia and post-NIV step down. Its advantages are that it is well tolerated in infants, allows oral feeding, has minimal claustrophobia. And when it fails, we can go ahead with NIV. NIV is used in certain conditions when there's post-extubatory respiratory failure, when there's atelectasis, which is unresponsive to HFNC, diaphragmatic splinting, phrenic nerve paralysis. It has a full face mask, and the problems are that children are often uncooperative with it, and we cannot feed while the NIV is on. So HFNC is preferred as the first line. If it fails, we can go ahead with NIV. And post-extubation, the child cannot perform infantile spirometry, so there are higher chances of airway compromise, collapse, atelectasis, but they can be positioned, suctioned, and actively physiotherapy. So we use both passive and active mechanisms. Passive mechanisms like upright positioning, 30 to 40% head up all times. The gravity pulls the abdominal contents down, unloads the diaphragm, position change every 2 hourly, gastric decompression using a RISE tube helps the child breathe easier. Active physiotherapy like chest physiotherapy and vibration every 10 to 15, it lasts 10 to 15 minutes, 3 to 4 times daily. Saline nebulization to loosen the secretions, nasal and oropharyngeal suctioning by Yonkers. This helps the child cough and take out the secretions. And post-extubation, analgesia and sedation should be given. Analgesia, if provided adequately, prevents splinting, but analgesia can cause sedation, which can cause CO2 retention. So a multimodal strategy should be used, which minimizes both the risk. Hepatic clearance is impaired post-liver transplant, so whatever should be started at a low dose. Ideally, we can, if required, we use paracetamol 8 hourly in a low dose, and when required, fentanyl can be given. For certain children who have difficulty breathing because of pain, Dexmed or ketamine infusion can be given, but that depends on the situation. Unique challenges which we face in infants post-extubation apnea. There are 5 mechanisms which conspire to produce apneic spells in the children. We should recognize them before extubation and prepare for the patients, not after. The large for size graft. Some grafts are larger in the children. That causes severe diaphragm displacement, decreases the lung compliance, causes rapid fatigue, and can lead to apnea. The open abdomen. Many patients have staged abdomen closure. A Bagota is used. The no rigid abdominal walls causes impaired intrathoracic negative pressure, can lead to exhaustion and apnea. Phrenic nerve dysfunction can happen in around 10 to 15% of the patients due to right diaphragm intraoperative stretch, retraction. This can be devastating in infants. The post-operatively, there's sluggish drug clearance. Is residual opioid sedative suppresses the respiratory drive in the neonates, and any metabolic disturbances can lead to pulmonary complications. Now, coming to the pulmonary complications we commonly see in the postoperative period, first and most common is atelectasis. This is due to small size of the airways. There are secretions which are stuck in the airways of the child that can lead to basal alveolar collapse or even whole lung collapse. This can be diagnosed easily by ultrasound and X-ray. And whenever it happens, active physiotherapy, positioning, NIV and PEEP, and if there's no response, bronchoscopy should be done. The next most common complication we face is pleural effusion, right-sided in 90% of the cases due to subdiaphragmatic fluid tracking, can be easily diagnosed on chest X-ray. It can be quantified on ultrasound, and management is to drain and put a PCD whenever there is respiratory compromise. VAP and pneumonia is the most devastating complication when it happens because the child is immunosuppressed. There's decreased mucociliary clearance. The most commonest are bacterial, followed by fungal and viral. So chest X-ray and ultrasound should be done daily, and it is easily diagnosed on ultrasound whenever there are increased bronchograms and a new patch appears on X-ray. Whenever this is seen, treatment should be started, antibiotics should be upgraded, a culture should be sent, and antibiotics should be started according to the culture once the report comes. The next most devastating complication, ARDS, happens in very low number of patients, but it can happen due to the IR injury, massive transfusion, sepsis, heart, and cytokine storm. There will be bilateral lung opacities. The child needs to be intubated as soon as the diagnosis is made, and a lung protective ventilation strategy should be done, and it should be treated as the condition of the patient. Bronchospasm is also a common complication. It occurs due to pre-existing reactive airway disease, which is common in biliary atresia, pre-op infections, and airway edema, and latex allergy. This cannot be diagnosed on X-ray, and clinical and ventilatory signs like wheeze, increased pressures point out to bronchospasm. Treatment includes salbutamol, ipratropium, magnesium, and if it is not treated, we can use IV magnesium and IV ketamine. Next comes the fluid management part. The paradox exists where adequate reload is vital for graft perfusion. Yet, if we give excess fluid, it will cause pulmonary edema, AKI, and prolonged mechanical ventilation. So there's a very fine line. In the first 72 hours, we should try to keep the child adequately filled because rapid IV fluid swings threaten the hepatic artery flow, which increases the thrombosis. So here we use replacement fluids are Plasma-Lyte and DNS. 5% albumin is the preferred volume expander, and it is albumin is given to replace the drain losses. In the initial days, 2/3 drain replacement is given. Urine output, weight, and input output chart should be monitored. In the initial 72 hours, we can keep the child a bit more filled. Once the patient becomes hemodynamically stable and the graft function stabilizes, we should target net even or mildly negative fluid balance. Then the drain losses are replaced with albumin, first half, then even 1/3 it can be done. Coagulopathy, again, post-operatively, there's a complication with thrombosis in the children. Whatever we use, we should use point-of-care testing, not standard INR or APTT. INR overestimates the bleeding risk, leads to unnecessary transfusion. Hepatic artery thrombosis, there's a high incidence in pediatric population due to low caliber vessels. TEG should be done, and a low-dose heparin infusion should be started accordingly. Nutritional management is important part. Surgical trauma plus high dose of steroids leads to severe catabolism. The calories requirement are 1.2 to 1.5 times the resting energy expenditure. Underfeeding should be avoided. Protein goals are 1.5 to 2.5 gram per kg per day. Glycemic goals are to maintain glucose between 90 to 180. Steroids and tacrolimus can cause hyperglycemia. The micronutrients and electrolytes should be replaced. Early enteral nutrition should be started with the NG or NJ tube as soon as possible. Maintaining the gut mucosal integrity decreases the bacterial translocation and bacteremia. TPN should be used cautiously when the child is not feeding. Again, infectious disease and immunosuppression management, there is a dual challenge. Immunosuppression is essential to prevent rejection, but this renders the child highly susceptible to opportunistic infections. Antibiotic prophylaxis is started. Here we use meropenem, teicoplanin, and metronidazole as our first line. Duration is guided by the drain cultures and the clinical trajectory. Any fever, investigate for biliary leaks, abscesses, central venous line infections. Immunosuppression protocol, the standard is followed. Intraoperative methylprednisolone is used. Steroids are tapered and child is started on oral steroids, and TAC and MMF are started from day one. But all this is individualized based on the prevailing infections and the condition of the kidney. I'll be coming to some cases from ILBS where we faced a lot of pulmonary complications. I'll be discussing a bit about the 4 cases. One is post-extubation apnea, 3 cases of weaning failure, which required tracheostomy. Coming to baby A, 1-year-old, post-biliary atresia at DLT, he was low-pelled. The intraoperative period went uneventful. Child was extubated on post-op day 1, was on HFNC. Post-operative day 3 at 2 a.m., there was an early warning. Child was irritable and crying with high respiratory rate. The ABG showed a pH of 7.26 and CO2 of 51. Physiotherapy and suctioning was done. The child was nebulized. At 6 a.m., there was full apnea, child apneic, he was not breathing, cyanosed peripheries, unresponsive to stimuli. ABG was done, pH was 7, CO2 of 93, severe hypercapnic respiratory failure. Immediate bag mask ventilation was done, emergency intubation was done, the child was stabilized. During the daytime, sedation was stopped, a successful PSV trial was given, and the child was extubated at 2 o'clock, 8 hours post the episode, and the HFNC was started. Why apnea happened? When the child was fine for 2 days, central apnea could have happened from residual opioid sedatives, as hepatic clearance is impaired in the first 72 hours. Young child, immature receptor response to hypercapnia. SpO2 was 98% on HFNC, which may be falsely reassuring. What action could have been taken when the CO2 was high, and high respiratory rate on HFNC? The child could have been started on NIV. So we could improve it here. Maybe proactively, if the CO2 is high, we can give NIV support. So this was a near miss, but the child was saved and extubated the next day. So we should be careful of post-transplant apnea. Coming to the next case, baby B, a 6.2 kg male child, biliary atresia, failed Kasai, had a high PELD, 34. It was a long duration 12-hour surgery. Clinical course post-op day 1 and 2 because of high inotropic support. The child was controlled on volume control ventilation. Post-op day 2, child was shifted to pressure support. The post-op day 3, after fulfilling the extubation criteria, the child was extubated. Despite fulfilling the extubation criteria, by evening, the child was tachypneic, distress, had poor respiratory effort, and had to be re-intubated. From post-op day 3 to post-op day 20, lot of weaning was tried, various modes of ventilation was tried, pressure support was tried to be reduced, but weaning failed repeatedly. On post-op day 20, tracheostomy was performed. Again on tracheostomy, multiple weaning attempts was done. Child could not be weaned. Whenever we tried to wean the child, patient desaturated. From post-operative day 25 onwards, a high-frequency tracheal oxygen trial was started. Tracheal cultures were done when required. Tracheostomy tube was changed. From post-operative day 25, we used high-frequency tracheal oxygenation as a weaning technique. We gradually increased the duration of high-frequency tracheal oxygenation from 30 minutes to 1 hour to 2 hours. By day 55, we could keep the child continuously on the high-frequency tracheal oxygenation. Day 56, the child was decannulated, and 62, he was discharged home. Come to another case, a 3-year-old with severe HPS. This child was 12.5 kg, failed Kasai with severe HPS. Rumia SpO2 was 88 and PA2 was 48. The child had a stormy intraoperative course requiring large volume blood transfusion. Post-operatively, our targets were to keep the PO2 between 50 to 60, but the child required 100% oxygen requirement and was on pressure control ventilation. Day 2 to 5, we tried to wean the child, shifted to PSIME, but still required 100% FiO2. For any reduction in FiO2 caused desaturation and tachypnea. So early tracheostomy was performed on day 6. Still, the weaning failure was there. Patient was given continuous PSV trials. There was desaturation on each attempt. From day 28 onwards, HFCO was initiated. Gradually, HFCO duration was increased, and child could be decannulated on day 47. Another child here, 18-month-old child, again post-biliary atresia. This child had a low PELD, was extubated immediately post-operatively. on the table, but day 6, due to raised tacrolimus levels or any other abnormality, child had altered sensorium, had CO2 retention and required re-intubation. Day 6 to 8, PI TAC levels normalized and repeated attempts were done to wean, but the weaning failed. Every time we tried to wean, the child had bronchospasm. That was treated with formoterol, ipratropium bromide, adrenaline, IV steroids. Still, we could not wean the child. So a decision to early tracheostomy was done. Patient was weaned from tracheostomy on day 18. So here in these cases, we used high frequency tracheal oxygenation. We use the HFNC machine with the interface which we can attach to the tracheostomy. How it helped wean our patients, it gives a passive PEEP effect. It gives optimal humidification to the patients, prevents mucosal drying, decreases the airway resistance, increases the mobility and comfort of the patients. By alternating between high-frequency tracheal oxygenation with PSV, we allowed the respiratory muscle to condition and the child could independently breathe. So what were the clinical learnings? 4 cases, there were 4 distinct mechanisms. One common theme as to anticipate, escalate early, and use a stepwise respiratory support strategy. Apnea is often preceded with a warning sign. Baby A had a CO2 51 at 2 a.m., which was the action point. SpO2 at that time was wrongly reassuring. Early tracheostomy, as seen in case 2 and baby C and D, it was done in 6 and 8, allows earlier rehabilitation. It allowed early oral feeds, physiotherapy, and nursing out of bed. High frequency tracheal oxygenation is a physiologically sound rescue for weaning failure, and hepatopulmonary syndrome requires a tailored ventilatory strategy. Low PO2 targets are acceptable. PO2 of 40 to 55 was initially accepted. FiO2 was high, 100%. And HPS resolved post liver transplant. Patience is a part of the strategy. Coming to the outcomes of liver transplant pediatric cases from 2024 to 2026, we had 34 children. Here are the extubation practices, risk factors and predictors of outcomes. We had 34 patients. This is only for CLD. We had another 15 ALF cases for pediatric that I'm not including here. The median age was 16.5 months. Median weight was 8.45 kg. Median PELD score was 22. Median GRWR was 3.34. The average median surgery duration was 11 hours 40 minutes. 32% patients had Bogota bag closure. Reintubation was required in 35% of the patient. Tracheostomy was required in 20% of the patients. ICU stay was 13 days. Mortality, we had 6 mortalities. Coming to the extubation group, immediate extubation on the table, we could extubate 11 patients, that is 32% of our cohort. Early extubation, post-op date, 29%, delayed extubation was 38%. So if we compare the groups, the factors which were coming statistically significant in early extubation are age, PELD score, and GRWR. Higher age, a lower PELD score, and lower GRWR favored extubation on table. Coming to the postoperative outcomes, reintubation was less common in immediate extubation. 2 patients still had reintubation. 1 was the case I discussed. Tracheostomy also was required in 1, but the ICU stay was less here, 10 days compared to the other 2 cohorts, and there was no mortality. So here we see that the immediate extubation phase group was more had good outcomes compared to delayed extubation. What are the predictors of outcome? Age and weight. Children less than 12 months had higher reintubation rates. Younger infants had immature respiratory muscles. They receive a larger graft size and they have decreased reserves. So we should be more watchful in these infants. Similarly, infants with weight less than 10 kg had higher chances of reintubation. So we should be careful with these patients. PELD score was a predictor. Lowest PELD score had good outcomes. That is obviously a known fact, as lowest PELD scores will have less severe disease, better hemodynamically stable. You can extubate them earlier. And lower GRWR was also a predictor of better outcomes. As higher GRWR, the larger graft can cause diaphragm displacement, increase the work of breathing post-extubation. So the summary and clinical implications for the 34 patient cohorts tells us immediate extubation is safe and achievable in 1/3 of our population. 11 out of 34 patients were extubated on the table. They were older, lower felt, and smaller GRWR. Zero mortality in this group supports immediate extubation in the OR as a goal and not as an exception. Delayed extubation is the group at highest risk. They had 38% had tracheostomy, higher ICU stay, and higher mortality. So from our case series, we learned that these patients need early tracheostomy and good weaning protocols. And reintubation rates is high in all our cohorts, even those patients who were extubated on the table. So there's a need for vigilant post-extubation monitoring. Coming to the final takeaways, in the post-operative management, precision hemodynamics should be there. Avoid profound hypotension and hypertension. Use norepinephrine vasopressin to maintain graft perfusion. Aggressive respiratory care is the cornerstone of ICU management. Anticipate mechanical barriers, lung protective ventilation, aim for early extubation, non-invasive support, and earlier tracheostomy. Good fluid and coagulation balance should be maintained. Maintain euvolemia. Track daily input-output. Albumin is the expander of choice. Use Teg-Rotem, not INR. Anticoagulate proactively for heart prevention. Metabolic and nutritional recovery is essential. Early enteral nutrition via NJ combats catabolism, prevents gut immunity. Target higher protein and caloric requirement. Thank you.
I think thank you, Udit and Shruti. I think very nice presentation. But is there any comment from Professor Tempe, Dr. Gaurav, anything? Just one or two comments. One is you gave us, PELD and A's and weight and all that, but there must have been some other post-op, immediate infections, and like you were talking about ARDS and all that. Should have given that data also, that how many of them had that, and otherwise it was a very comprehensive presentation.
I think very nice presentations, Dr. Udit and Shweta. Children per se, especially those who are less than 5 kilo, are a great challenge to the anesthesiologist undergoing any type of surgery. And especially if the surgery is of the nature of liver transplant, which lasts for hours together, the challenges are even more compounded. They start with the securing of the lines, and I remember sometimes we spent a couple of hours in securing all the lines. And maintaining homeostasis, electrolyte acid-base balance for extended period of time is also a great challenge. Add to that any surgical problems, such as the cross-clamping, the IVC, unexpected hemorrhage, injury to the vascular structures or adhesions adds to these problems. I'm very happy to say that the team of anesthetists comprising of Gaurav, Udit, and Anil are very competent anesthesiologists, and Shweta, Priyanka, and Sonam are very rapidly catching up. Good anesthetic backup is extremely important for successful liver transplant, and IL-Base is very fortunate to have a very competent anesthetic department. Comments about the presentation. I think you could have added the role of NIRS during intraoperative management. Number two, in the postoperative management, ventilator-induced diaphragm dysfunction, which we have been doing. We are measuring the diaphragm excursion and thickening fraction, which helps the decisions related to weaning. And of course, we could have shown some more lung ultrasound pictures showing the B lines, B profile, or the pneumonitis or bronchograms, air bronchograms. We could have included in the presentations. So overall, it has been an excellent learning for a very comprehensive presentation. And thank you for your presentation. Gaurav, you want to say something?
Thank you, sir. Thank you for your kind words. Dr. Udit and Dr. Shweta, it was a wonderful presentation covering almost all aspects of pediatric liver transplant anesthesia, which is still not very common in most parts of India. So, as we all know that we have come a long way and we have seen remarkably improved outcomes in these patients. And still, I remember a time when putting lines in these patients used to be a nightmare. I still remember a couple of cases where we have to stop the donor surgery because we were facing a lot of difficulties in putting lines on the recipient side, especially in the small babies. So we have come a long way from facing a difficulty in putting lines to doing on-table extubation. And I still remember in 2018 when we introduced the high-flow nasal cannula, it actually proved to be a game changer for these patients. With the introduction of HFNC in these patients, we were actually able to extubate them early, and now, in fact, we are doing most of the time doing early extubation, on-table extubation, as shown by Dr. Udit, where we have done on-table extubation in almost 33% of the patient with 0% mortality. So this is quite a remarkable achievement in terms of the outcomes. If you see, there is no mortality in that group, and which is almost 33% of these patients. So early extubation could be actually the only important factor which determines the post-transplant outcomes or the long-term outcomes of these patients. And finally, I would say that pediatric patients, they have a very high resilience and they are actually the true fighters. And we have seen them recovering even after months on months of ventilation, as shown in two of the cases where we have ventilated them almost for 2 months. Managing this patient for 2 months on small tube of size of 3 or 3.5 is not an easy job with so much of coagulopathy. So that way, I would say it's definitely a wonderful job, and I must congratulate to my complete team and under the supervision of Tempe sir and Arora sir. So thank you very much.
I think thank you. And I must apologize, Shweta. I was saying Shruti, so I must apologize for that.
Thank you.